So, a very warm good morning to everyone. Today, I'll be speaking about liver and heart crosstalk in critical ill cirrhotics, Pocus in the focus. So, it's actually both of them are quite extensive topics. So, we'll shortly discuss about the pathophysiology of liver and heart in critical ill cirrhotics and then focus on the 2D echo part of this talk. So, as we all know, heart failure and liver disease can coexist due to the complex cardiohepatic interactions. Heart failure may lead to liver disease, which can adversely affect the prognosis and it can complicate the management of heart failure. Conversely, liver disease itself may cause cardiac dysfunction or failure in absence of other cardiovascular abnormalities. So here we can see as like some systemic disorders or disease like alcohol abuse, drugs, inflammatory disorders, autoimmune disorders, and infection can affect the heart and liver both at the same time. So firstly, we'll move on to how is the liver affected in presence of heart failure. Although we don't get many patients in our setup, but it's worthwhile knowing this. There are two mechanisms involved in this. One is ischemia reperfusion injury and the other is hepatic congestion. So hyperperfusion induced due to hypoxia, it can cause cellular damage in patients with heart failure. This can lead to activation of Kupper cells, the neutrophils, intracellular calcium overload, cytokines and chemokine activation, which ultimately leads to disruption of the liver microcirculation. And this majorly occurs in the zone 3 of the liver. The other mechanism by which it can affect the liver is hepatic congestion. As we all know, there are no valves in the hepatic veins. So increase in the IVC pressure due to heart failure, it can affect the sinusoidal bed, which can lead to central lobar congestion, sinusoidal dilatation and periveneal fibrosis. It usually starts in the zone 3 of the liver but may extend into the peripheral area, ultimately leading to cirrhosis. Now, the two conditions in this in patients with heart failure we can come across is acute cardiogenic liver injury and congestive hepatopathy. The incidence of acute cardiogenic liver injury is around 20 to 30%, and it usually occurs in a background of a congested liver, in which the hepatocytes they compensate for the impaired blood flow by increasing the oxygen extraction. And on top of that, if heart failure occurs, this mechanism is exhausted, which can lead to hypoperfusion along with liver congestion, which can lead to acute cardiogenic liver injury. And the other thing is congestive hepatopathy. It is found more in patients with left ventricular assist device systems, with the incidence of around 15 to 65%. The underlying pathophysiology being increased hepatic venous pressures, decreased hepatic blood flow, and decreased arterial oxygen saturation. Now coming on to how the heart is affected in presence of liver disease. So we know that in patients with liver disease there is a high incidence of coronary artery disease as compared to normal coronary artery disease. The incidence can go up to as high as 16 to 27%, with increased incidence in patients more than 50 years of age, and it is usually associated with risk factors like diabetes, hypertension, hyperlipidemia and smoking. Also non-alcoholic fatty liver disease, in these patients there is an increased risk of cardiomyopathy, valvular calcifications, arrhythmias and conduction blocks. Also patients might be having portopulmonary hypertension, in which the mean pulmonary artery pressures are more than 25 mm of Hg, wedge pressure is around less than 15 millimeters of mercury, and the pulmonary vascular resistance is more than 3 Wood units. And the most commonly associated conditions in patients with liver disease is cirrhotic cardiomyopathy. Now recently the Cirrhotic Cardiomyopathy Consortium has come up with a criteria in 2019. It can be associated with systolic and diastolic dysfunction. So in the systolic dysfunction, they look at the ejection fraction, which will be less than 50%, or the absolute GLS, that is a global longitudinal strain. This is what they have come up with in the new criteria. So just a word about GLS. So the strain in the heart, it can be circumferential, longitudinal, radial or transverse. So the convention left ventricular ejection fraction, what we look at, it usually reflects the radial function of the heart. So what they have found is the longitudinal function of the heart is lost prior to the radial function of the heart, and this is where GLS comes into help. GLS can identify the contractile dysfunction in those with preserved LVEF, and it expresses the myocardial longitudinal shortening as a percentage, that is change in the length during systole as a proportion to the baseline length at diastole. It's normally a negative number, and the values of less than -16 are considered to be abnormal, whereas more than -18 is normal, and -16 to -18 is borderline. And the other factors like and the other condition is diastolic dysfunction. In this, they have given that three or more of the criteria should be present for a diagnosis of diastolic dysfunction, in which they have calculated septal E prime velocity, that is the early diastolic mitral annular velocity by 2D echo, which should be less than 7 centimeters per second, and E by E prime ratio, that is a mitral inflow early diastolic velocity, has to be more than 15. The left atrial volume index should be more than 34, and the tricuspid regurgitation velocity should be more than 2.8. Now they have come with some other factors which could be present and which requires further validation, are like electromechanical uncoupling, myocardial mass change, serum biomarkers, and chamber enlargement. So what are the cardiovascular pathology that occurs in end-stage liver disease? So basically there will be left ventricular hypertrophy with increased left atrial volume. There will be reduced in the contractile response to stress and diastolic dysfunction. There can be portopulmonary hypertension with increased right-sided pressures. These patients, as we know, are in the state of peripheral vasodilatation. There can be blunted heart rate variability because most of the patient might be on beta blockers, and also due to the reduced beta 2 response. There can be prolonged QT interval on ECG. They are also known to have hyperdynamic circulation with increased cardiac output at baseline, and also, like I said, blunted response in cardiac output with physiological stress. Now, this is just a summary of how the LV function, liver function, and the circulatory function, it progresses as the disease progresses from normal to preclinical to compensated and then to decompensated state. So as you can see, in decompensated state, there can be eccentric hypertrophy, diastolic and systolic dysfunction, complicated with decompensations like cirrhosis, ascites, and HRS. And also in circulatory dysfunction, there can be vasodilatation, decreased cardiac output, along with prolonged QT, LA dilatation, increase in the left ventricular end diastolic volume, and decreased ejection fraction. So what happens if these patients, they have, if they present to us with sepsis or any other life-threatening conditions? So in the setting of decreased SVR and increased pancreatic pooling, there will be decrease in the effective center.
Anil, to interrupt, can you go to the previous diagram?
Yes.
Previous. So is there a rate of cardiac remodeling depend on compensated to decompensated? Any details on cardiac remodeling, wall thickness, ejection fraction? You have shown with this graph, but how much time?
So actually, the time duration hasn't been mentioned, but there are few like myocardial mass change. They have mentioned in this article that it requires further validation and it requires further studies to come up with a cutoff key how much it increases from baseline to in the decompensated state.
Like left ventricular index, volume index, and others, are there any indices?
Yes, sir. Left atrial volume index they have given, which is more than 34 ml per meter square.
No, ventricle.
Ventricle they have not given, sir. They have given about the atrium only, sir.
The lowest one is left atrial volume index.
Volume
left
indices.
atrial ventricular indices are not there.
No, sir. So these patients, they are in the state of, they usually have decreased SVR with increased pancreatic pooling, which leads to a decrease in the effective central circulating volume, which is compensated by activation of the neurohormonal mechanisms, leading to increased cardiac contractility and salt and water retention. On top of that, if they have an episode of sepsis, this micro and macrovascular vasodilatory effects are exaggerated further, which leads to decrease in the effective circulating volume and potentiating the neurohormonal response. So when these patients present to us in the ER or in the ICU, they can have decreased lactate clearance, further peripheral vasodilatation, which can they can have existing cardiovascular dysfunction, relative adrenal dysfunction, hypoalbuminemia due to the chronic nature of the disease, and they are more susceptible to infection as the immune system is decreased in chronic liver diseases. So this is actually a very important figure to show that how the fluid response, about the fluid responsiveness in these patients. So there are three components in this figure: the mean systemic filling pressure, the venous return, and the cardiac output. So this is what happens in the normal patient. There is adequate mean systemic filling pressure, which leads to adequate venous return and which leads to adequate cardiac output. So in patients with cirrhosis, what happens is they are in the state of vasodilatation. So they have the mean systemic filling pressure is usually on the lower side, which leads to decrease in the venous return, which is compensated by increase in the chronotropic or the inotropic action, which leads to an adequate cardiac output. So, but when these patients, they present to us with sepsis or septic shock, what happens is there is further vasodilatation, which leads to further decrease in the mean systemic filling pressure, which leads to inadequate venous return, and the compensatory response, the chronotropic and the inotropic compensatory response, it's inadequate, and so they might be having a low cardiac output. So our initial response in this patient is to resuscitate them with fluid, rightly with fluids, but this can also harm the patient in the respect that if they are overfilled with fluids, it can lead to capillary leak. So in these patients with cirrhosis and septic shock, they are filled with fluid. If the filling pressures are adequate to a certain limit, the MSAP can increase and it can lead to adequate cardiac output. But overzealous administration of fluid can lead to capillary leak, volume overload, and in this state, it will lead to inadequate venous return. This is where a restrictive fluid strategy along with early use of vasopressors comes to use. So this is a patient with cirrhosis plus septic shock. So we have given the we have resuscitated the patient with initial fluid till the filling pressures are adequate, and then after that we start early vasopressor, which can lead to adequate venous return and adequate cardiac output. Also, it's worthwhile mentioning the Frank-Starling curves in patients with septic shock. So the upper curve is a normal curve. So we'll always like to be in the steep part of the curve. So this is delta P is a change in the pressure, and this is a change in the stroke volume. So if you are in the steep part of the curve, the change in the pressure will give rise to increase in the stroke volume. Whereas the curves becomes flatter and flatter, the change in the pressure does not give to as much change in the stroke volume as much as we like, and further increase in the as the curve becomes flat, this increase in the stroke volume becomes less and less. So this is in a non-stressed heart in a normal cardiac patient. So in cirrhosis patients, they already have a compromised heart, in which the increase in the pressure give rise to increase in the stroke volume only after a certain limit of time. After that, it leads to a increase in the stroke volume. So we'd always like to be on this part of the curve even in cirrhosis patients. So what are the goals of resuscitation in these patients? Initially it was recommended that early goal-directed fluid therapy is useful, in which basically goal-directed through fluid therapy is usually targeting a specific value like a mean arterial pressure or hemoglobin or CVP or central venous oxygen saturation with the help of fluids or inotropes to achieve a specific target. However, it was recognized that it doesn't lead to improve in the mortality, and it leads to increase in the hospital cost. So currently, the goals, it aims at reversing the derangement which has caused the sepsis or the shock, like maintaining adequate mean arterial pressure, renal and brain hypoperfusion, and decreasing the lactate levels. The target map which they have recommended is around 60 to 65 millimeters of mercury. Early use of antibiotics and antifungals, as they are more prone for infections. Fluid in the state fluids, usually balanced salt solutions are used, and since these patients they have high incidence of endothelial damage, albumin is widely used in these patients. Restrictive fluid strategy with early use of inotropes or vasopressors, and point of care ultrasound along with dynamic indices for guiding the fluid therapy. Now moving on to the next part of the class, that is use of ultrasound or echo in these patients. So these are the general indications of cardiac ultrasound to assess the global LV function in cases of cardiac arrest, to see the heart contractility, whether it is contracting or not. In cases of chest pain with ECG changes, estimating the CVP, hypotension, sepsis, and in some cases trauma. So how does ultrasound help us in a critically ill cirrhotic patient? It can help us identifying the underlying cause, whether it is a hypovolemic shock or a cardiogenic shock. In hypovolemic shock, the heart won't be contracting. I mean, there won't be adequate filling of the heart. We can have a quick assessment of the cardiac function in these patients, the volume status, detection of any valvular abnormalities. It can also be used to guide for procedures like putting CVP lines and arterial lines. And the most important should be the monitoring response to therapy. Like doing it for one time or a single point is not useful. It should be done at least twice or thrice in a day, and it should be repeated every day on the same patient to see the response of therapy. Otherwise, one-time use is not doing it for a one time is not very useful. And it can also be used in assessment of life-threatening conditions like pericardial tamponade and effusion. So coming on to what kind of probe do you use? So we know that there are three kinds of probe commonly used in ultrasound. This is the linear probe, curvilinear probe, and this is the phased array probe or the cardiac probe. So it's divided based on the frequency. So the phased array probe and the curvilinear probe usually have the same frequency, but the curvilinear probe it's used for doing abdominal ultrasound, like visualizing the abdomen, gallbladder, kidney, liver, bladder, etc. Although they have the same frequency, there is very major difference between these two probes. Is basically the piezoelectric crystals which are there. It is centered and packed in the center of the probe in case of cardiac probe, which makes it very useful to place it between the ribs and use for a cardiac examination. The curvilinear probe also can be used, but it won't. I mean, the resolution and the penetration won't be that good as compared to the phased array probe. And the other probe, the linear probe, it's usually a high frequency probe. So the higher the frequency, the lesser is the penetration in these probes. So it's usually used for putting central lines and arterial cannulations. So this is the choice of the probe. It's a frequency of around 1 to 5 megahertz. It's commonly used for doing cardiac echo, E-fast, or assessing the IVC. And it's due to its size, it's easier to get in between the small spaces like the ribs. So one should always make sure that you know where the indicator is pointed while doing any examination, doing any ultrasound examination. So there are basic few differences between doing cardiac ultrasound and an abdomen ultrasound. The first most important difference is when you're doing a normal ultrasound, abdomen ultrasound, or any other putting lines or anything, the indicator which is there on the ultrasound, it's on the right side of the screen, whereas in the cardiac, it is on the left side of the screen. So you always have to make sure that when you're doing a cardiac ultrasound, if it is not on the right side of the screen, there is always a button to switch it on the right side of the screen, or convert the settings. From the settings, you can convert into cardiac preset and shift this this indicator on the right side of the screen. So coming on to the basic cardiac views, there are there are 5 views and at 3 specific points which can be done. The first is the parasternal view. So this is the parasternal view. Second is the apical. Third is a subxiphoid. So it's always a good idea to go from parasternal to subxiphoid to apical in a clockwise manner. And always it's good to assume that a heart is an inverted cone-like structure with the apex at this point, and here is the base. So in the parasternal long axis, we have 2 views: parasternal long axis and parasternal short axis. The long axis is commonly known as the Plaque's view. Another is a short axis view. The other is the apical view. Then the subxiphoid view, we can have the subxiphoid subcostal view and the inferior vena cava view. Now coming on to the first view, which is the most commonly used view. It is usually the first view to obtain the Plaque's view or the parasternal long axis view. It is used for the quick assessment of the ejection fraction and the ventricular function. The probe indicator, as I mentioned, is to the patient's right shoulder, and the probe is in the 4th intercostal space in males and in the inframammary fold for to the sternum in females. But it's actually a very good practice to start it from the clavicle below, because in some patients, like in our setup, we mostly have patients with tense ascites. This heart may be shifted maybe 1 or 2 subcostal space above. So it's a good practice to start just below the clavicle and then go 1 rib space below at a time. Or in patients with COPD, it might be slightly lower than the 4th intercostal space. Now here is a video depicting the parasternal long axis view. So as I mentioned, the indicator should be on the right side of the patient, and this is a schematic. What we hope to see in this picture is the left atrium draining into the left ventricle, which drains further into the aorta. This is the aortic valve into the left ventricle outflow tract. Here is the right ventricle, and it's very important that you recognize the descending aorta in this view, because I'll tell you the significance of that later. But these are the structures we are hoping to see in this view. So this is the LA, this is left atrium draining into the left ventricle, this is the mitral valve, this is the aortic valve, and this is the left LVOT. This is the right ventricle on the top, and this is the descending aorta. Now why it is important to recognize the descending aorta in this view is because if there is a fluid above the descending aorta, it is most likely a pericardial effusion. And if there is a fluid below the aorta, it's most likely a pleural effusion. So if you want, I'll just play the video once again. So this is the left atrium draining into the left ventricle, aortic wall, mitral valve, and the LVOT, RV, and the descending aorta. So how do we estimate the ejection fraction from this view? So the standard method or the gold standard method, what they recommend is eyeballing, in which we see the squeeze of the heart, that is squeeze of the left ventricle here, and how good the anterior mitral valve leaflet is flapping against the interventricular septum. This is the RV, this is the LV, and this is the interventricular septum. So how good the anterior mitral valve leaflet is flapping against the IV interventricular septum and the squeeze of the left ventricle, we have to see in this this thing. So in this we can see that the anterior mitral valve leaflet is nicely flapping against the interventricular septum, and there is good squeeze of the LV. Could have been a more better, but in this we can say that the ejection fraction is more than 50%. As compared to this, the anterior mitral valve leaflet is not totally going and hitting the IV interventricular septum, and the squeeze is also less as compared to the previous. This you can label it as moderately reduced ejection fraction, around 30 to 50%. As compared to this, the anterior mitral valve leaflet is hardly moving in this, and even the ventricles are hardly moving and squeezing. So this will be a severely depressed left ventricle. So this is usually a standard method. You can have a quick eyeball and find out roughly how much is the ejection fraction in these patients. The other method is quantifying the ejection fraction with a method which is called as EPSS, or E-point septal suppression. In this, what we do is we obtain a parasternal long axis view. So this is a parasternal long axis view with LA, LV. This is the mitral valve, RV, and the descending aorta. And what we do is we freeze the image and put an M mode on the anterior mitral valve leaflet. So once we put the M mode, we'll get this image on the screen. This is the interventricular septum, and the two curves are the mitral valve. So as we have noticed, if you want, I can play the video again. In this the mitral valve flaps twice. So if you can see, in one heartbeat it will flap twice. So those are the two curves on the graph. So one is basically due to the passive filling, and the other is due to the atrial kick. So in EPSS, what we do is we measure the distance between the interventricular septum and this passive filling part of the mitral valve, and if it is less than 7 millimeters, it is a normal heart. More than 10 millimeters, it represents LV dysfunction. So these are few videos depicting what are things we can pick up in the parasternal long axis view. So as I mentioned, you have to always look for the descending aorta. This is the descending aorta, LA, emptying into the LV, although not properly visualized. This is the LA into the LV, and then the LVOT. So there is, you can see fluid around this, which is anterior to the descending aorta. So fluid around the heart, which is anterior to the descending aorta. So this is most likely a pericardial effusion. And the other thing is pericardial effusion along with tamponade. So when do you call it as a tamponade? Basically, it's basically pericardial effusion along with diastolic collapse of the ventricle, or any clinical symptoms of hypoperfusion like hypotension, tachycardia, syncope, shortness of breath, or chest pain. So in this we can see this diastolic collapse of the RV, impaired filling of the LV, and this pericardial fluid around the heart. So this is most likely a pericardial tamponade. Also, RV strain due to any acute event like pulmonary embolism, it will give us to a dilated RV. So in this we can make out the dilated RV in this view actually. So this is the LA draining into the LV, and this is a dilated RV. It's almost bigger, or it's in the size is almost bigger than the LV. So this is most likely a pericardial pulmonary embolism. Coming on to the next view, parasternal short axis view. In this view, from the plaques view, what we have obtained, the indicator was on the right side of the patient. We just need to keep the probe there and rotate the probe 90 degrees, so that now the indicator probes, it points toward the patient's left shoulder. In this we can obtain three views, but to start with we'll try to obtain the mid papillary view. So in this what we do is we point the indicator to the patient's right shoulder in the same position from left to right, somewhere around 1 o'clock to 2 o'clock, and this is a schematic representing that we can see the LV in cut section short axis. So we are seeing the LV in cut section, and behind that is encircling is the RV, and here we can see the papillary muscles, and below that is the lung. So just like to propose an algorithm of point of care ultrasound in critical ill cirrhotics. First, evaluate the global function. Is there any cardiac activity? This is usually relevant in patients who have recently coded or have an cardiac arrest. If the LV function is good, if it is it normal or is it severely depressed? If it is normal, we can. Is there any presence of any pericardial fluid around the heart? If it is minimal fluid, we can let it go. If it is compressing the RV free wall, it can be pericardial tamponade. Also, the next thing will be to evaluate the IVC. It is collapsing, whether it is collapsing or not collapsing with respiration, and always look for anything additional. That is, do you see anything new or unusual in this echo? And always ask for opinion if you have any problems. Summary: heart and liver work in close association with each other. Echo emerges as an indispensable bedside and non-invasive tool for quick assessment of heart and overall volume status. It should be integrated with routine clinical practice, and practicing it daily is a key to master the skill. And always be patient while performing a bedside ultrasound, because you might not get things in first attempt. You will always have to keep doing it again and again every day. And just to mention, this Pocus 101, it's a free app available on all the smartphones nowadays. It has a very good application, and it's all the cardiac, lung and abdominal ultrasounds are given in a very nice manner in this app. It's a free download and you can use it without logging in also. So, thank you.